Lewis's Medical Surgical Nursing, 11th edition, Chapter 17, Pre-Operative Care. Surgery is the art and science of treating diseases, injuries, and deformities by operation and instrumentation. The total surgical episode is called the perioperative period. This period includes the time before surgery, preoperative period, the time spent during the actual surgical procedure, intraoperative period, and the period after the surgery is over, postoperative period. The surgical experience involves an interprofessional team, including the patient, surgeon, anesthesia care provider, ACP, nurse, and other healthcare team members. Preparing patients for surgery is an important nursing role. This chapter discusses preoperative care that applies to all surgical patients. Preparation measures for specific surgical procedures, e.g. abdominal, thoracic, or orthopedic surgery, are discussed in the appropriate chapters of this book. Surgery is performed for many reasons. These include diagnosis, determine the presence and extent of a pathologic condition, e.g. lymph node biopsy, bronchoscopy. Cure, eliminate or repair a pathologic condition, e.g. removal of ruptured appendix or benign ovarian cyst. Palliation, alleviate symptoms without cure, e.g. cutting a nerve root, rhizotomy to reduce pain, creating a colostomy to bypass an inoperable bowel obstruction. Prevention, reduce risk of developing a condition, e.g. removal of a mole before it becomes malignant, removal of the colon in a patient with familial polyposis to prevent cancer. Cosmetic improvement, alter physical appearance, e.g. repairing a burn scar, breast reconstruction after a mastectomy. Exploration, determine the nature or extent of a disease, e.g. laparotomy. With the use of advanced diagnostic tests, exploration is less common because we can identify many problems non-invasively. Surgical procedures are usually described by combining specific suffixes with the body part or organ, table 17.1. Surgical settings. Surgery may be a carefully planned event, elective surgery, or may arise with unexpected urgency, emergency surgery. Both elective and emergency surgeries are done in a variety of settings. The type of surgery, potential complications, and the patient's health status influence the setting where a patient can safely undergo a surgical procedure. For inpatient surgery, patients who are going to be admitted to the hospital are usually admitted on the day of surgery, same-day admission. Patients who are in the hospital before surgery are usually there because of acute or chronic medical conditions. Most surgical procedures are performed as ambulatory surgery, also called same-day or outpatient surgery. Many of these surgeries use minimally invasive techniques, e.g. laparoscopic techniques. Ambulatory surgery often occurs in endoscopy clinics, physicians' offices, freestanding surgical clinics, and outpatient surgery units in hospitals. These procedures can involve the use of general, regional, or local anesthetic. Patients require less than a 24-hour stay after surgery. Many go home with a caregiver within hours of surgery. Patients and HCPs often prefer ambulatory surgery. Generally, it requires fewer laboratory tests and medications and reduces the patient's risk for healthcare-associated infections. Patients like the convenience of recovering at home. HCPs prefer the flexibility in scheduling. The costs are usually less for the patient and the insurer. You play an essential role in preparing the patient for surgery, caring for the patient during surgery, and aiding the patient's recovery after surgery. To perform these functions effectively, first, know the reason the patient is undergoing surgery and any comorbidities. Second, identify the individual patient's response to the stress of surgery. Third, know the results of preoperative diagnostic tests. Last, identify potential risks and complications associated with a surgical procedure and any special considerations that should be addressed in the plan of care. The nurse caring for the patient before surgery is likely to be different from the nurse in the operating room, OR, post-anesthesia care unit, PACU, surgical intensive care unit, SICU, or surgical unit. Communication and documentation of important preoperative assessment findings are essential for quality care. Patient interview. One of the most important nursing actions is the preoperative interview. The nurse who works in the physician's office, ambulatory surgery center, or hospital may do the interview. The preoperative interview can occur in advance or the day of surgery. The primary purposes of the patient interview are 1. To obtain the patient's health information, including drug and food allergies, 2. Provide and clarify information about the planned surgery, including anesthesia, and 3. Assess the patient's emotional state and readiness for surgery, including his or her expectations about surgical outcomes. The interview gives the patient and caregiver an opportunity to ask questions about the surgery, anesthesia, and post-operative care. Often, patients ask about taking their routine drugs, such as insulin, anticoagulants, or heart medications, and if they will have pain. By being aware of the patient's and caregiver's needs, you can provide the information support needed during the perioperative period. Nursing assessment of preoperative patient. The overall goal of the preoperative assessment is to identify risk factors and plan care to ensure patient safety throughout the surgical experience. To achieve this, you will need to do the following. Establish baseline data for comparison in the intraoperative and postoperative period. Determine the patient's psychologic status to reinforce the use of coping strategies during the surgical experience. Determine physiologic factors directly or indirectly related to the surgical procedure that may contribute to operative risk factors. Participate in the identification and documentation of the surgical site according to agency protocol. Identify prescription drugs, over-the-counter drugs, and herbs taken by the patient and may result in drug interactions affecting the surgical outcome. Review the results of all preoperative diagnostic studies in the patient's record and share this information with the appropriate HCPs. Identify cultural and ethnic factors that may affect the surgical experience. Determine if the patient received adequate information from the surgeon to make an informed decision to have surgery and that the consent form is signed and witnessed. Subjective data. Psychosocial assessment. Surgery is a stressful event, even when the procedure is minor. The psychologic and physiologic reactions to surgery may elicit the stress response, e.g., elevated BP and heart rate. The stress response enables the body to meet the demands in the perioperative period. If stressors or responses to the stressors are excessive, the stress response can be magnified and may affect recovery. Many factors influence the patient's reaction to stress, including age, past experiences with illness and pain, current health, and socioeconomic status. The use of common language and avoidance of medical jargon are essential. Use words and language that are familiar to the patient to help the patient understand the surgery. Familiar language also helps reduce anxiety. Your role in psychologically preparing the patient for surgery is to assess the patient for potential or actual stressors that could negatively affect surgery. Table 17.2. Communicate all concerns to the appropriate surgical team member, especially if the concern requires intervention later in the surgical experience. Because many patients are admitted directly into the preoperative area from their homes, you must be skilled in assessing important psychologic factors in a short time. The most common psychologic factors are anxiety, fear, and hope. Anxiety. Most people are anxious when facing surgery because of the unknown. This is normal and is an inborn survival mechanism. However, a high anxiety level can impair cognition, decision-making, and coping abilities. Anxiety can arise from lack of knowledge. This can range from not knowing what to expect to uncertainty about the outcome and may result from past experiences or stories heard through friends or the media. You can decrease some anxiety for the patient by giving information about what to expect. This is often done through classes or web-based or audiovisual teaching materials before surgery. Inform the surgeon if the patient needs more information or has excessive anxiety. Patients may have anxiety when surgery conflicts with their religious or cultural beliefs. Identify, record, and communicate patient decisions about the possibility of blood transfusions. For example, Jehovah's Witnesses may choose to refuse blood or blood products. Common fears. Patients fear surgery for many reasons. The most common fear is the risk for death or permanent disability resulting from surgery. Sometimes the fear comes after hearing or reading about the risks during the informed consent process. Other fears are related to pain, change in body image, or results of diagnostic procedures. Fear of death can be extremely harmful. Notify the HCP if the patient has a strong fear of death. A patient's strong fear of impending death may prompt the HCP to delay the surgery because the emotional state influences the stress response and thus the surgical outcome. Fear of pain and discomfort during and after surgery is common. If the fear is extreme, notify the ACP or the surgeon. Reassure the patient that drugs are available for anesthesia and analgesia during surgery. For pain after surgery, tell patients to ask for pain medications before pain becomes severe. Teach the patient how to use a pain intensity scale, e.g., 0 to 10, FACES. See Chapter 8 for more on pain scales. The patient may receive drugs that provide an amnesic effect so that the patient will not remember what occurs during surgery. Tell the patient that helps decrease anxiety after surgery. Fear of mutilation or an altered body image can occur whether the surgery is radical, such as amputation, or minor, such as breast biopsy. Even a small scar on the body can upset someone, or others fear keloid development, overgrowth of a scar. Listen to and assess the patient's concern about this fear with an accepting attitude. Fear of anesthesia may arise from the unknown, personal experience, or tales of others' bad experience. These concerns can also result from information about the risks of anesthesia, e.g., brain damage, paralysis. Many patients fear losing control while under anesthesia. If you identify any of these fears, inform the ACP at once so that he or she can talk further with the patient. Fear of disruption of life functioning may be present in varying degrees. It can range from fear of permanent disability to concern about not being able to engage in activities of daily living for a few weeks. You may find concerns about loss of role function, separation from family, and how the family will manage. Financial concerns include dealing with an expected loss of income and the costs of surgery. If you find any of these fears, a consult with the patient caregiver, a social worker, spiritual advisor, or a psychologist may be appropriate. Financial advisors at the hospital may be able to give information about financial support. Hope. Although many psychological factors related to surgery seem to be negative, hope is a positive attribute. Hope may be the patient's strongest method of coping. To deny or minimize hope may negate the positive mental attitude necessary for a quick and full recovery. Some patients hopefully anticipate surgery. These can be the surgeries that repair, e.g., plastic surgery for burn scars, rebuild, e.g., total joint replacement to reduce pain and improve function, or save and extend life, e.g., repair of aneurysm, organ transplant. Assess and support the presence of hope and the patient's anticipation of positive results. Past health history. Ask the patient about any previous health problems and surgeries. Determine if the patient understands the need for surgery. For example, the patient scheduled for a total knee replacement may say that increasing pain and immobility are the reasons for the surgery. Record the reason for any past hospitalizations. Include previous surgeries and the dates. Identify any problems with previous surgeries. For example, the patient may have had a wound infection or a reaction to a drug. Ask women about their menstrual and obstetric history. This includes the date of their last menstrual period, the number of pregnancies, and any history of cesarean section. When obtaining a family health history, ask the patient and caregiver about any inherited traits, since they may contribute to the surgical outcome. Record any family history of heart and endocrine diseases. For example, if the patient reports a parent with hypertension, sudden cardiac death, or myocardial infarction, this should alert you to the possibility that the patient may have a similar predisposition or condition. Obtain information about the patient's family history with adverse reactions to or problems with anesthesia. For example, malignant hyperthermia has a genetic predisposition. If present, measures will be taken to decrease complications associated with this condition. Medications. Document all current medication use, including OTC drugs and herbs. Many surgery centers ask patients to bring their medications with them when reporting for surgery. This helps to accurately assess and document the name and dosage of medications. The interaction of the patient's current drugs and anesthetics can increase or decrease the desired physiologic effect of anesthetics. Consider the effects of opioids and prescribed drugs for chronic health conditions, e.g., heart disease, hypertension, depression, seizure disorder, diabetes. For example, certain antidepressants can potentiate the effect of opioid agents used for anesthesia or pain control. Antihypertensive drugs may predispose a patient to shock The combined effect of the drug and the vasodilator effect of some anesthetic agents. Insulin or oral hypoglycemic drugs may need adjustments during the perioperative period because of increased body metabolism, decreased oral intake, stress, and anesthesia. Anti-platelet drugs, e.g. aspirin, Plavix, and non-steroidal inflammatory drugs, NSAIDs, inhibit platelet aggregation and may contribute to postoperative bleeding. HCPs may have patients withhold medications before surgery. Specific time frames for withholding medications depend on the medication and the patient. Patients on long-term anticoagulation therapy, e.g. warfarin, Coumadin, Xarelto, Pradaxa, Eliquis, present a unique challenge. The options for these patients include 1. Continuing therapy, 2. Withholding therapy for a time before and after surgery, 3. Withholding the therapy and starting subcutaneous or IV heparin therapy during the perioperative period. The management strategy selected is based on the patient history and the nature of the surgery. Ask about the use of herbs and dietary supplements because their use is so common. Many patients do not think to include supplements in their list of medications. They believe that herbal and dietary supplements are natural and do not pose a surgical risk. Excess use of vitamins and herbs can cause harmful effects in patients undergoing surgery. In those taking anticoagulants or antiplatelets, herbal supplements can produce excess postoperative bleeding that may require a return to the OR. The Complementary and Alternative Therapies box lists the effects of specific herbs that are of concern during the perioperative period. Ask the patient about any substance use. Most likely used substances include tobacco, alcohol, opioids, marijuana, cocaine, and amphetamines. Ask questions about use in a frank manner. Stress that substance use may affect the type and amount of anesthesia the patient will need. When patients become aware of the potential interactions of these substances with anesthetics, most patients respond honestly about using them. Chronic alcohol use can place the patient at risk because of lung, GI, or liver damage. Decreased liver function prolongs the metabolism of anesthetic agents, alters nutritional status, and increases the potential for postoperative complications. Alcohol withdrawal can occur during lengthy surgery or in the postoperative period. Proper planning and management are needed to avoid this life-threatening event. Record and share all findings of the drug history with the perioperative healthcare team. The ACP will decide the best schedule and dose of the patient's routine drugs before and after surgery. Ensure that you identify all the patient's drugs, implement any changes in the medication plan, and monitor the patient for potential interactions and complications. Allergies. Ask the patient about drug intolerances and drug allergies. Drug intolerance usually results in side effects that are unpleasant for the patient but not life-threatening. These effects include nausea, constipation, diarrhea, or idiosyncratic, opposite than expected, reactions. A true drug allergy produces hives and or an anaphylactic reaction, causing cardiopulmonary compromise, e.g. hypotension, tachycardia, bronchospasm. Being aware of drug intolerances and drug allergies helps the healthcare team maintain patient comfort and safety. Record all drug intolerances and allergies and, if needed, place an allergy identification ban on the patient on the day of surgery. Ask about non-drug allergies, specifically food and environmental, e.g. latex, pollen, animals, allergies. The patient with a history of any allergic reactions has a greater potential for hypersensitivity reactions to drugs given during anesthesia. Screen all patients for latex allergies by gathering data about risk factors, contact dermatitis, contact urticaria, e.g. hives, aerosol reactions, history of reactions that suggest an allergy to latex. Risk factors for latex allergy include long-term, multiple exposure to latex products, such as those experienced by healthcare and rubber industry workers. Other risk factors include a history of hay fever, asthma, and allergies to certain foods, e.g. eggs, avocados, bananas, chestnuts, potatoes, peaches. Latex allergies are discussed in Chapter 13. Review of systems. The last part of the patient history is the body systems review. Ask specific questions to confirm the presence or absence of any diseases. Current health problems can alert you to areas that you will need to examine in the preoperative physical examination. A combined review of systems and patient history provides essential data to determine the specific preoperative tests the patient needs. Cardiovascular System. Evaluate cardiovascular function to determine pre-existing disease or problems, e.g., coronary artery disease, prosthetic heart valve. In reviewing the CV system, you may find a history of hypertension, angina, dysrhythmias, heart failure, or myocardial infarction, MI. Ask about the patient's current treatment for any CV condition, e.g., drugs, and the level of functioning. Cardiology consult is often needed before surgery if the patient has a significant CV history, e.g., recent MI, valvular heart disease, implantable cardioverter, defibrillator. If indicated, the patient should have a 12-lead ECG and coagulation studies, and the results should be on the chart before surgery. The CV assessment provides data on what other measures the patient needs. For example, the patient who is on diuretic therapy needs to have a serum potassium level drawn before surgery. If the patient has hypertension, the ACP may give vasoactive drugs to maintain adequate BP during surgery. The patient with a prosthetic heart valve may receive antibiotic prophylaxis before surgery to decrease the risk for infective endocarditis. Venous thromboembolism, VTE, a condition that includes deep vein thrombosis and pulmonary embolism, is a concern for any surgical patient. Patients at high risk for VTE include those with a history of previous thrombosis, blood clotting disorders, cancer, varicosities, obesity, tobacco use, heart failure, or COPD. People are also at risk for developing a VTE because of immobility and positioning during the operative procedure. Intermittent pneumatic compression devices, IPCs, may be applied in the pre-operative holding area. Respiratory system. Ask the patient about any recent or chronic respiratory disease or infections. Elective surgery may be postponed if the person has an upper respiratory tract infection. Upper airway infections may increase the risk for bronchospasm, laryngospasm, decreased O2 saturation, problems with respiratory secretions. Report a patient's history of dyspnea at rest or with exertion, coughing, dry or productive, or hemoptysis, coughing blood, to the ACP and surgeon. If a patient has a history of asthma, ask about the use of inhaled or oral corticosteroids and bronchodilators, as well as the frequency and triggers of asthma attacks. The patient with a history of COPD is at high risk for pulmonary complications, including hypoxemia and atelectasis. Gather information about the patient's tobacco use. The HCP and you should encourage the patient to stop smoking at least 6 weeks before surgery. Smoking increases the risk for pulmonary complications during and after surgery. Report conditions likely to affect respiratory functions such as sleep apnea, obesity, and spinal, chest, and airway deformities. For example, patients are often asked to bring their sleep apnea devices with them to the hospital or surgical center. Depending on the patient's history and physical examination, baseline pulmonary function tests and arterial blood gases may be done before surgery. Neurologic system. Evaluation of neurologic functioning includes assessing the patient's ability to respond to questions, follow commands, and maintain orderly thought patterns. Changes in the patient's hearing and vision may affect responses and the ability to follow directions throughout the perioperative assessment and evaluation. Record the patient's ability to pay attention, concentrate, and respond appropriately to establish a baseline for postoperative comparison. If you know deficits in cognitive function, determine the extent of the problem and whether they can be corrected before surgery. If the problems cannot be corrected, it is important to involve a legal guardian or person with durable power of attorney for healthcare to aid the patient and provide informed consent for surgery. Preoperative assessment of the older person's baseline cognitive function is especially crucial for a comparison during and after surgery. The older adult may have intact mental abilities before surgery, but is more prone to adverse outcomes during and after surgery than the younger adult. This is due to the added stressors of the surgical procedure, dehydration, hypothermia, and anesthesia, and adjunctive drugs. These factors may contribute to the development of emergence delirium, a condition that may be falsely labeled as senility or dementia. In the review of the neurologic system, obtain about any history of strokes, that's a typo, transient ischemic attacks or spinal cord injury. Ask about neurologic diseases such as myasthenia gravis, Parkinson's disease, and multiple sclerosis, and any treatments used. Genitourinary system. Assess for a history of renal or urinary tract diseases such as chronic kidney disease or repeated urinary tract infections. Record the present disease state and current treatment. Renal dysfunction is associated with several problems, including fluid and electrolyte imbalances, coagulopathies, increased risk for infection, and impaired wound healing. Because the kidneys metabolize and excrete many drugs, a decrease in renal function can lead to an altered response to drugs and unpredictable drug elimination. Renal function tests, e.g. serum creatinine, blood urea nitrogen, BUN, are often done before surgery. Record and share with the perioperative team if the patient has problems voiding, e.g. incontinence, hesitancy. Older male patients may have an enlarged prostate that can interfere with the insertion of a bladder catheter or impair voiding after surgery. For a woman of childbearing age, determine if she is pregnant or thinks she could be pregnant. Most agencies perform a pregnancy test for all women of childbearing age before surgery. Immediately tell the surgeon if the patient states that she may be pregnant. Maternal and fetal exposure to anesthetics should be avoided during the first trimester. Hepatic system. The liver is involved in glucose homeostasis, fat metabolism, protein synthesis, drug and hormone metabolism, and bilirubin formation and excretion. The liver detoxifies many anesthetics and adjunctive drugs. The patient with hepatic dysfunction may have an increased perioperative risk for clotting abnormalities and adverse responses to drugs. Consider the presence of liver disease if there is a history of jaundice, hepatitis, alcohol abuse, or obesity. Integumentary system. Ask about a history of skin problems. Assess the current condition of the skin, especially at the incision site, for rashes, breakdown, or other skin conditions. A patient with a history of pressure injuries may need extra padding during surgery. Skin problems can affect wound healing. Body art such as tattoos and piercings are increasingly common. When possible, select pigment-free areas for injections, IV sites, and laboratory draws. Musculoskeletal system. Note any musculoskeletal and mobility problems, especially in the older adult. If the patient has arthritis, identify all affected joints. Mobility restrictions may influence intraoperative and postoperative positioning and ambulation. Spinal anesthesia may be difficult if the patient cannot flex the lumbar spine enough to allow easy needle insertion. If the neck is affected, intubation and airway management may be difficult. Any mobility aids, e.g. cane walker, should be with the patient on the day of surgery. Endocrine system. The patient with diabetes is especially at risk for adverse effects of anesthesia and surgery. Hypoglycemia, hyperglycemia, delayed wound healing, and infection are the common complications of diabetes during the postoperative period. Clarify with the surgeon, or ACP, whether the patient should take the usual dose of insulin or oral hypoglycemic agents on the day of surgery. ACPs may vary the usual insulin dose based on the patient's status and history of glucose control. Measure serum or capillary glucose levels the morning of surgery to establish baseline levels. Assess the patient's glucose levels regularly and, if necessary, manage according to agency protocol. Determine if the patient has a history of thyroid dysfunction. Hyperthyroidism or hypothyroidism can place the patient at surgical risk because of changes in metabolic rate. If the patient takes a thyroid replacement drug, check with the ACP about administering the drug on the day of surgery. If the patient has a history of thyroid dysfunction, laboratory tests may be done to determine current levels of thyroid function. The patient with Addison's disease needs special consideration during surgery. Addisonian crisis or shock can occur if the patient abruptly stops taking replacement corticosteroids. The patient may need additional IV corticosteroid therapy from the stress of surgery. Immune system. Note if the patient has a history of a compromised immune system or takes immunosuppressive drugs. Corticosteroids used in immunosuppressive doses may be tapered before surgery. Impairment of the immune system can lead to delayed wound healing and increased risk for infections. Elective surgery may be canceled if the patient has an acute infection, e.g., sinusitis, influenza. Patients with active chronic infections such as hepatitis B or C, acquired immunodeficiency syndrome, or tuberculosis may have surgery if needed. However, when preparing the patient for surgery, remember to take infection control precautions for the protection of the patient and staff. Infection control guidelines are discussed in Chapter 14. Fluid and electrolyte status. Ask the patient about any recent conditions that increase the risk for fluid and electrolyte imbalances, such as vomiting, diarrhea, or completing a bowel prep. Identify drugs that change fluid and electrolyte status, such as diuretics. Serum electrolyte levels are often assessed before surgery. Many patients may have restricted fluids for a specific period of time before surgery. They could develop dehydration if surgery is delayed. A patient with or at risk for dehydration may need more fluids and electrolytes before or during surgery. Complete a preoperative fluid balance history for all patients. This is especially critical for older adults. Their reduced adaptive capacity leaves a narrow margin of safety between overhydration and underhydration. Nutritional status. Nutritional problems include overnutrition and undernutrition, both of which need considerable time to correct. However, knowing that a patient has a nutritional problem can help the healthcare team provide more customized care. For example, if the patient is thin, place more padding than usual on the OR table. Notify the team if a patient is severely obese, BMI greater than 40 kilograms per meter squared, to allow time to obtain special equipment needed for the patient's care, e.g., longer instruments for abdominal surgery. Obesity stresses the heart and lung systems and makes access to the surgical site and anesthesia administration more difficult. It predisposes the patient to wound dehiscence, wound infection, and incisional herniation after surgery. Adipose tissue is less vascular than other types of tissue. The patient may be slower to recover from anesthesia because adipose tissue absorbs and stores inhalation agents, so they leave the body more slowly. See Chapter 40 for the special needs of obese patients undergoing surgery. Nutritional problems impair the ability to recover from surgery. Remember that the obese patient or the very thin patient can be protein and vitamin deficient. If the problem is severe, surgery may be postponed. Protein and vitamins A, C, and B, complex deficiencies, are particularly important because these substances are essential for wound healing. Patients who are malnourished may receive supplemental nutrition during the perioperative period. The older adult is often at risk for malnutrition and fluid volume deficits. Identify patients who consume large quantities of coffee or caffeinated soft drinks. In many cases, withholding caffeinated beverages before surgery or for some time after surgery can lead to severe withdrawal headaches. These headaches can be confused with spinal headaches if the preoperative data are not recorded. Giving caffeinated beverages after surgery, when possible, may prevent these headaches. Objective data. Physical examination. The Joint Commission requires that all patients admitted to the OR have a documented history and physical examination, H&P, in their chart. This may be done in advance of surgery or on the day of surgery. Any qualified HCP, including advanced practice nurses, physicians, physician assistants, or ACPs, may perform the H&P. Findings from the H&P enable the ACP to assign the patient a physical status rating for anesthesia administration. This rating is an indicator of the patient's perioperative risk and may influence perioperative decisions. It uses a scale of P1 to P6. A rating of P6 is reserved for a brain-dead patient undergoing organ procurement. Patients undergoing surgery in ambulatory or outpatient settings generally have ratings of P1, P2, or P3. Other designations can be added to the ASA status, e.g. E to designate an emergent procedure. Complete a physical examination of the patient before surgery. Review the documentation already present in the patient's chart, including the H&P, to better proceed with your examination. Record all findings and share any relevant findings at once with the surgeon or ACP. Diagnostic Studies. Obtain and assess the results of diagnostic studies ordered before surgery. For example, a patient taking an anti-platelet drug, e.g. aspirin, may have a coagulation profile done, or a patient on diuretic therapy may have a potassium level checked. A woman of childbearing age may receive a pregnancy test. An ECG is done for many who take drugs for dysrhythmias or have high blood pressure. Patients with diabetes undergo blood glucose monitoring. In many settings, patients are tested for methicillin-resistant Staphylococcus aureus. Those with positive results are prescribed antibiotics for several days before surgery. Ideally, preoperative tests are ordered based on the patient's H&P. However, many agencies and insurers have protocols for preoperative tests, which may not include all those in Table 17.5. In addition, some tests may be done days before surgery. Ensure that all laboratory and diagnostic reports are in the patient's chart. Missing reports may result in a delay or cancellation of the surgery. Nursing management. Preoperative patient. Base the preoperative nursing interventions on the nursing assessment, depending on the patient's specific needs. Pending surgery and routines of the surgery setting guide the patient's physical preparation. Preoperative teaching may be minimal or extensive. The Association of Perioperative Registered Nurses, AORN, provides standards and recommend practices to guide nursing interventions in all perioperative settings. Preoperative teaching. The patient has a right to know what to expect and how to take part effectively during the surgical experience. Preoperative teaching increases patient satisfaction and can reduce postoperative fear, anxiety, and stress. Teaching may decrease the development of complications, length of hospitalization, and recovery time after discharge. In most surgical settings, patients often arrive only a short time before their surgery. Preoperative teaching for these patients generally occurs in the surgeon's office or a pre-admission surgical clinic and is reinforced on the day of surgery. After ambulatory surgery, the patient usually goes home several hours after recovery, depending on the patient's progress and procedure-specific needs. Teaching must include information that focuses on the patient's safety. Give written materials for patients and caregivers to use for review and reinforcement at home. Discharge teaching is required for all patients. When delivering teaching, find a balance between explaining so much that the patient is overwhelmed and telling so little that the patient is unprepared. If you observe and listen carefully to the patient, you can usually figure out how much information is enough. Remember that anxiety and fear may limit learning ability. Assess what the patient wants to know and give priority to those concerns. Generally, preoperative teaching includes 3 types of information: sensory, process, and procedural. Different patients with varying cultures, backgrounds, and experience may want different types of information. See Table 4.6 for factors affecting patient teaching. With sensory information, patients find out what they will see, hear, smell, and feel during the surgery. For example, you may tell them that the OR will be cold, but they can ask for a warm blanket. The lights in the OR are bright, or many unfamiliar sounds and specific smells will be present. Patients wanting process information may not want specific details, but just the general flow of what is going to happen. This information would include the patient's transfer to the holding area, visits by the nurse and the ACP before transfer to the OR, and waking up in the PACU. With procedural information, patients desire details that are more specific. For example, this information would include saying an IV line will be started while the patient is in the holding area, and the surgeon will mark the operative site with an indelible marker to verify the surgical site. Share the preoperative teaching given to the patient with the nurses providing postoperative care to evaluate learning and avoid duplication of teaching. Because there is limited time for teaching, a team approach is often used. For example, teaching may start in the outpatient setting. Your responsibility is to assess the patient's understanding of this teaching and fill in the gaps at this point in the surgical process. Record all teaching in the patient's chart. A guide for preoperative patient and caregiver teaching is outlined in Table 17.6. See Chapter 4 for more on patient and caregiver teaching. General surgery information. Unless it is contraindicated, e.g. after craniotomy, tonsillectomy, all patients should receive instruction about deep breathing, coughing, and early ambulation postoperatively. This is essential because patients may not want to do these activities after surgery unless they know the reason for them and practice them before surgery. Tell patients and caregivers if tubes, drains, monitoring devices, or special equipment will be used after surgery. Explain that these devices help you safely care for the patient. Examples of specific teaching may include how to use incentive spirometers or patient-controlled analgesia pumps. Patients should have a clear understanding of how to rate their pain and how their pain will be managed. The patient should also receive surgery-specific information. For example, a patient having a total joint replacement may have an immobilizer after surgery. Tell a patient having open heart surgery about waking up in the intensive care unit. Ambulatory surgery information. The ambulatory surgery patient or the patient admitted to the hospital the day of surgery needs to receive information before admission. Some ambulatory surgical centers telephone patients several days before the procedure to obtain health information, give instructions, and answer questions. Each center has policies and procedures for communicating this information. In addition to specifics on the procedure, patients need information on day of surgery events such as arrival time, registration, parking, what to wear, what to bring, and the need to have a responsible adult present for transportation home after surgery. Traditionally, we tell patients having elective surgery to have nothing by mouth, NPO, starting at midnight on the night before surgery. Evidence-based guidelines for healthy patients of all ages undergoing elective surgery, except women in labor, from the American Society of Anesthesiologists are less strict. Restricting fluids in food is designed to reduce the risk for pulmonary aspiration and nausea and vomiting. Protocols may vary for the patients having local anesthesia or surgery scheduled late in the day. Follow the NPO protocol of each surgical setting. The patient who has not followed the NPO instructions may have surgery delayed or canceled. It is critical that the patient understands the reasons for and follows all restrictions. Legal preparation for surgery. Legal preparation for surgery consists of checking that all required forms have been correctly signed and are present in the patient's chart, and that the patient and caregiver clearly understand what is going to happen. Standard consent forms include those for the surgical procedure and blood transfusions. Other forms may include advance directives and durable power of attorney for healthcare. Consent for surgery. Before non-emergency surgery can be legally performed, the patient must voluntarily sign an informed consent form in the presence of a witness. Informed consent is an active, shared decision-making process between the HCP and recipient of care. 3 conditions must be met for consent to be valid. First, there must be adequate disclosure of the 1. Diagnosis, 2. Nature and purpose of the proposed treatment, 3. Risks and consequences of the proposed treatment, 4. Probability of a successful outcome, 5. Availability, benefits, and risks of alternative treatments, and 6. Prognosis if treatment is not instituted. Second, the patient must show a clear understanding of the information before receiving sedative preoperative drugs. If a patient is sedated prior to signing a consent, surgery may be canceled or delayed. Third, the recipient of care must give consent voluntarily. The patient must not be persuaded or coerced in any way by anyone to undergo the procedure. The surgeon is ultimately responsible for obtaining the patient's consent for surgical treatment. You may be asked to witness the patient's signature on the consent form. At this time, you must be a patient advocate, verifying the patient understands the information in the consent and the implications of consent, and that consent for surgery is truly voluntary. If the patient is unclear about the surgical plans, contact the surgeon about the patient's need for more information. The patient should be aware that consent, even when signed, can be withdrawn at any time. If the patient is a minor, unconscious, or mentally incompetent to sign the permit, a legally appointed representative or responsible family member may give written permission. An emancipated minor is one who is younger than the legal age of consent, but is recognized as having the legal capacity to provide consent. Procedures for obtaining consent vary among states and agencies. Follow your state's Nurse Practice Act and agency policy that apply to a specific situation. A true medical emergency may override the need to obtain consent. The next of kin may give consent when immediate medical treatment is necessary to preserve life or prevent serious impairment to life or limb, and the patient is incapable of giving consent. If reaching the next of kin is not possible, the HCP may begin treatment without written consent. A note in the chart must document the medical necessity of the procedure. In the case of an emergency in which consent cannot be obtained, you will usually need to complete an event report because it is an occurrence that is inconsistent with routine agency practices. Day of surgery preparation. Nursing role. Day of surgery preparation varies a great deal depending on whether the patient is an inpatient or an ambulatory surgical patient. Your responsibilities immediately before surgery include final preoperative teaching, assessment, and communication of pertinent findings. In addition, ensure that all preoperative orders are done and that the chart is complete and goes with the patient to the OR. It is especially important to verify the presence of a signed informed consent form, results of laboratory and diagnostic studies, an H&P, a record of any consultations, baseline vital signs, proper skin preparation, and completed nursing notes. The surgical site is identified and marked with an indelible marker by the surgeon and documented to show that the patient agrees. Hospitals often require that a patient wear a hospital gown with no underclothes. Surgical centers may allow the patient to wear underwear, depending on the procedure. The patient should remove any cosmetics, since observation of skin color is important. Remove nail polish and artificial nails so you can assess capillary refill and pulse oximetry. Place an identification band on the patient and, if applicable, an allergy band. Return all patient valuables to a caregiver or secure according to agency policy. All prostheses, including dentures, contact lenses, and glasses, are generally removed to prevent loss or damage. If electrocautery devices will be used during surgery, jewelry and piercings must be removed as a safety measure. Leave hearing aids in place to allow the patient to follow better instructions. Return glasses to the patient as soon as possible after surgery. Encourage the patient to void before you give preoperative drugs and perform transfer to the OR. An empty bladder prevents involuntary elimination under anesthesia and reduces the risk for urinary retention during the early post-operative recovery. Many preoperative drugs interfere with balance and increase the risk for a fall during ambulation. Carefully assess each patient for responses to drugs given and adjust the plan of care as needed. Preoperative medications. Preoperative medications are used for a variety of reasons. A patient may receive a single drug or a combination of drugs. Benzodiazepines are used for their sedative and amnesic properties. Anticholinergics are sometimes given to reduce secretions. Opioids may be given to decrease pain and anesthetic requirements during surgery. Antiemetics can decrease nausea and vomiting. Other drugs that may be given before surgery include antibiotics, eye drops, and routine prescription drugs. Antibiotics may be given throughout the perioperative period for patients with a history of prosthetic heart valve to prevent infective endocarditis and for patients with previous joint replacement. They also may be given when wound contamination is a potential risk, e.g., GI surgery. Antibiotics are most often given IV. We often give a single or first dose within 30 to 60 minutes of the surgical incision. People with known hypertension or coronary artery disease may receive beta blockers to control BP or reduce the chances of MI and cardiac arrest. Those with diabetes are carefully monitored and may receive insulin in the preoperative period. Eye drops are often given prior for the patient undergoing cataract and other eye surgery. Many times, the patient will need multiple sets of eye drops given at 5-minute intervals. It is important to give these drugs as ordered and on time to adequately prepare the eye for surgery. Patients may or may not receive drugs they routinely take on the day of surgery. To aid patient teaching and remove confusion about which drugs patients are taking, carefully check written preoperative orders and clarify the orders with the surgeon and/or ACP if there is any question. Preoperative drugs may be given by mouth, PO, IV, or subcutaneously. Provide PO drugs with a small sip of water 60 to 90 minutes before the patient goes to the OR unless otherwise ordered. Subcutaneous injections, e.g. insulin, and IV drugs are usually given to the patient after arrival in the preoperative holding area. Teach the patient about the expected effects of the drugs, e.g. drowsiness. Transportation to the operating room. For inpatients, transport staff move the patient by stretcher to the OR. Help the patient in moving from the bed to the stretcher and raise the side rails. Ensure that the completed chart and any needed equipment goes with the patient. In many agencies, the caregiver may go with the patient to the holding area. In an ambulatory surgical center, the patient may go to the OR by stretcher or wheelchair. If no sedatives have been given, the patient may even walk with someone to the OR. In all cases, it is important to ensure patient safety during transport. Record the method of transportation and the person who transports the patient to the OR. Provide the handoff communication to the nurse receiving the patient. This allows each of you to ensure you have shared all pertinent information about the patient. To avoid adverse events related to miscommunication, AORN recommends the use of the S-bar model for the handoff process in this setting. Show the caregiver where to wait for the patient during surgery. Many hospitals have a surgical waiting room where OR staff communicate the patient's status to the caregiver and let them know when the surgery is complete. The surgeon can find the caregiver in this room after surgery to discuss the outcome. Some hospitals give pagers to caregivers so that they may eat or do errands during the surgery. Culturally competent care. Preoperative patient. Include cultural considerations when asking and implementing care for the patient's preoperative needs. For example, culture often determines one's expression of pain, family expectations, and ability to verbally express needs. One's culture may require that the family be included in any decision making. For example, many older Hispanic women may defer to their family for the decision whether to have surgery. Respect these decisions. If the patient or caregiver does not speak English, you must use a qualified interpreter, translates orally, or translator, interprets written text, communications system. See more on culturally competent care in Chapter 2. Gerentologic Considerations. Preoperative patient. Many patients older than 65 years of age undergo surgery. Surgery on older adults requires careful evaluation. Frequently performed procedures in older adults include cataract surgery, coronary and vascular procedures, prostate surgery, cholecystectomy, and joint repair or replacement. Communication is important. The patient's primary HCP is usually not the surgeon. Often several HCPs are involved in the patient's care. Be particularly alert when assessing and caring for the older adult surgical patient. An event that has little effect on a younger adult may be overwhelming to the older patient. Hospitalization may represent a physical decline and loss of health, mobility, and independence. The older adult may view the hospital as a place to die or as a stepping stone to the nursing home. Help to decrease anxieties and fears while maintaining the self-esteem of the older adult during the surgical experience. The risks associated with anesthesia and surgery increase in the older patient. In general, the older the patient, the greater are the risks for complications after surgery. In planning care, consider the patient's physiologic status, not only the chronologic age. The surgical risk in the older adult relates to normal physiologic aging and changes that comprise organ function, reduce reserve capacity, and limit the body's ability to adapt to stress. This decreased ability to cope with stress, often compounded by the burden of one or more chronic illnesses, and the surgery itself, increase the risk for complications. Confirm and document the patient's goals and treatment preferences. In those with advanced directives, Discuss any new risks associated with the surgical procedure. Make sure the approach for treating any potential problems is consistent with the patient's preferences. Older adults may have some sensory deficits. Bright lights may bother those with eye problems. They can have reduced vision and hearing. Thought process and cognitive abilities may be slowed or impaired. Assess and record baseline sensory and cognitive function. Physical reactions are often slowed because of mobility and balance problems. Because of these changes, the older adult may need more time to complete preoperative testing and understand preoperative instructions. These changes also require you to pay more attention to promote patient safety and prevent injury. When older adults live in a long-term care or assisted living facility, you may need to coordinate transportation from these facilities so that timely arrival allows for surgery preparation. A legal representative of the patient must be present to provide consent for surgery if the patient cannot sign for himself or herself. Finally, determine the presence of or need for caregiver support for the older adult undergoing surgery. With the increase in outpatient surgical procedures and shorter length of stays after surgery, caregiver support is critical in the continuity of care for this population. Lewis's Medical Surgical Nursing, 11th edition, Chapter 17, Pre-Operative Care.